for example, a supraclavicular block, interscalene block, you will most likely see something abnormal. It's important when you picked it up, at least, refer appropriately. And of course, abscess. I've helped quite a number of surgeons, particularly when we're dealing with cold abscess, when it's not really shiny and red outside, and they have difficulty in locating it. So it's much easier for them to actually, we identify where it is, and then, the incision is going to be very accurate. Okay, where are we? We've talked about the past, and then a bit, of course, quite significantly about the present. Where are we going to go in the future? So we have seen from card-based, this is probably a bit more, I would say, compact card-based, to laptop-based, and now we have, tablets or phones being attached to probes, and these can actually function as an ultramobile ultrasound system. There have been a recent, not so recent publication, some 2017, in circulation of this handheld echo machines or handheld ultrasound systems. Ultrasound has been made sexy now. This is actually a butterfly promotion image. There've also been ultrasound, for example, Clarius, which is actually wireless, and you can attach it to your phone, and the phone becomes an ultrasound. This article just illustrates to us, because of the access of ultrasound, there have been a democratization of ultrasound. Everybody can get access to ultrasound, and I think it's a good thing that there are a lot more companies coming into the market. For example, Wisonic is coming to the market, and hopefully, when there's more competition, it's actually good for the consumers. So now the concept of focus is probably now purses, where they say that it's personal ultrasound. Everybody can actually afford to actually own an ultrasound system. And 2018 as well, in JAMA, it was proposed that it's maybe time for us, the medical fraternity, to add the fifth pillar of bedside examination, from just inspection, palpation, percussion, and auscultation, which is very traditional, what we were taught in medical school, and now to include insonation as well. So apart from just auscultation, it's important now for us to insonate as well. Sometime last year, New York Times published it. So basically what a group of volunteer workers did from the US did was actually, in a mission, they brought this butterfly systems. And what they did was actually diagnose pneumonia. See, these are all patients who are most likely will have TB if they have chronic pneumonia. And instead, of having ultrasound, which is nearly impossible in this doing chest X-ray in this resource-limited environment, they brought ultrasound and made a diagnosis of chronic lung conditions. And again, this was the emergency physician that actually brought the system and documented the use of this phone ultrasounds. There've also been, for example, this is a study which hasn't been published yet, but I actually listened to the presentation by Save the Children, one of the international humanitarian NGOs. What they did was actually funded the study to look at whether in the resource-limited humanitarian environment, ultrasound can be actually safely performed to diagnose the pediatric pneumonia. I guess with all the evidence that we've talked about and I touched about, I think it's time for us to actually embrace point-of-care ultrasound. And this was actually a 2017 Communication article where they were looking at, incorporating focus into the perioperative medicine. There've also been a paper on, this was a 2016 paper on basically training, anesthesiology training, and incorporating all the various modalities of point-of-care or perioperative ultrasound into residency training in North America. So we now have artificial intelligence. I know I grew up at least with Terminator and Matrix, and we know that this was actually at that point in time was more like a fantasy. We know it was a sci-fi, scientific fantasy. But actually, Hollywood is usually a step forward. And now we can actually, most of our ultrasound machines do have AI features. For example, this is actually a concept paper written in 2018, what the authors did was looking at the possible applications of deep learning. For example, in this cardiac focus, estimation of cardiac ejection fraction, IVC, diameter, and so on and so forth. There's also applications and examples of deep learning for the lung ultrasound. I won't go into details, but technically this is a concept paper. So I'm just going to highlight this particular features of the Wisonic ultrasound. So if you could look at this, so what the ultrasound is able to do for those untrained eye to actually show the practitioner that this is actually nervous tissue. This is the nerve, and this is where you should actually guide your needle to. So this is actually artificial intelligence. The machine is able to actually learn and recognize structures and assist the clinicians to actually identify the structures. For in this particular interest, is actually the brachial plexus. There are also other systems. For example, this is a calculation of the VTI, or the volume time integral, calculation of the IVC, as well as calculation of the B lines. There have also been systems, for example, you put the ultrasound and the machine can actually just calculate. This is a calculation of the bladder volume. So how do we train? There have been, the conventional training, that we normally do, which is the workshops, and then you have this mentorship, where a trainer trains a trainee over a certain period of time. But if you do not have access to that, there are various other modalities. For example, of course, you have the web-based training. This is actually a decent website, Ultrasound USRA, a Toronto website. And even in this particular website, there's actually POCUS. There's actually a subsection of POCUS. There have been other, this is a machine that I've used in Singapore, which is a hard work. So instead of having a model and having an ultrasound and then working on the model, this is actually a mannequin, and it's actually what it does is actually detects the probe and generates an image, and not just generate an image, but actually can show the trainee the various anatomy of the heart. So again, this is actually an image of the heart works. More recently, there have been, for example, this is SonoSim. So it's actually a probe with this particular instrument. What you do is, subscribe, and then with the subscription, the internet program or software is able to actually function as if you're owning an echo simulator. So I think I would end my first talk with just this caption. This was actually a 2016 publication, perioperative ultrasound. Even after 2016, I think the future is still now, because the uptake is probably not as much as I would like to see, because I think, for example, emergency medicine and intensive care is probably adopting point of care ultrasound much faster than anesthesiologists. Thank you. I'm going to now shift straight to my second lecture. Okay.
Okay, thank you, Dr. Sharidan. I think as you are preparing for your second lecture, for the participants, if you do have any inquiries or for our Q&A session later, please do post it in through the Q&A button or the chat, and we'll read out your question. Okay, Dr. Shah, you ready?
Yes. Okay, so lung ultrasound for the anesthesiologist. I won't go into great detail, because actually to talk on lung ultrasound, and I think in the interest of time, we probably have about 10 odd minutes or so. It's more on the technique or the basic technique on how to perform it. I'm just going to skim through some of the evidence. Okay, again, this is my association. This was the original paper by Lichtenstein in 1993, the father of lung ultrasound, where he documented the use of ultrasound in his ICU, 150 patients, of which he had a handful of patients who had empyema, pleural effusion, apical pleural effusion. with patient with ARDS. So this was one of the earlier documentation of the use of lung ultrasound in the ICU. And then eventually, the article that I showed you earlier, this is a 2012 recommendations by the WinFocus group. And again, I showed you this earlier, 2007, Lucaneri and Ricostotis EBCDE approach of point of care ultrasound. Again, this is what I showed you earlier. And in anesthesia, there's no mention of actually lung ultrasound. It's actually in critical care medicine, there's actually pulmonary assessment, which is lung ultrasound. So where we are today, this is the original article, 2011, anesthesiology on the diagnosis, 2 cases of pneumothorax perioperatively. And this is where, the mainstream of TE, vascular access, and ultrasound guided has been challenged with other modalities. One of the first few articles was this, the use of lung ultrasound to look at lung consolidation and air bronchogram. There have been various studies quite recently perioperatively. This is lung ultrasound in diagnosing anesthesia-induced atelectasis in children. And also lung ultrasound in atelectasis after general anesthesia. So something that we can use, particularly if we have patients who desaturate, perioperatively, or even do not desaturate but are high risk for atelectasis, we can actually perform lung ultrasound and as I mentioned in my earlier talk, use lung recruitment to actually look at the success of the lung recruitment. This is actually a review article, 2016 in BJ Education. Again, this is a review article, but this is a Romanian journal, probably not so. There have been also intraoperative lung ultrasound, a clinical dynamic perspective. More recently, this was published, the Journal of Cardiothoracic and Vascular Anesthesia, perioperative lung ultrasound for cardiothoracic anesthesiologists, lung recruitment in children. Just to show, from this is where the wet lung to a probably slightly reduced number of B lines. I'll show you earlier, in my later slides. Again, every recruitment, I think I showed this in my first lecture. I'm not going to go into detail. There was also a review article in RPM. And this is, they evaluated the use of lung ultrasound against chest X-ray in diagnosing post-operative pulmonary complications after cardiothoracic surgery, and they found that the lung ultrasound was a lot better in diagnosing post-op complications. Again, in pediatric cardiac surgery. So in terms of evidence, there's actually very good and evidence out there to actually use lung ultrasound in the perioperative period. But how do we do it? Okay, so we can use all probes, but technically the more common one is the curvilinear probe or the linear probe, and it has to be the indicator usually cath lab or by as a standard. When you look at the transverse view, the indicator is usually on the right side of the patient. But all probes have actually been used and has actually been used in most studies. So you can use all the probes, but you must understand the limitation. For example, if you use a linear probe that you know that you're not going to go anything, the image that you see will not go deeper than 5 centimeters. Okay, this is how you see. Because I would recommend that you, as you do a longitudinal scan first for screening, and if you have anything abnormal, then only move to a transversal scan. This is the division of the topography. For example, if you want to document, then you say FL1, the left side one. So this is the anterior axillary line, and this is the posterior axillary line. And of course, we have the 5-6, but you must also remember that you have a scapula here. So usually the scan will be paraspinal. Okay, so let's scan. Okay, this is a normal lung. Let's see what a normal lung looks like on the ultrasound scan. Okay, can you see this is actually a shadow of the rib, and this is actually